Our final presenter is Dr. Mabel Awar, who is a veterinarian and currently working on an MPH in field epidemiology at Ahmadu Bello University in Nigeria. Her interests include zoonoses and outbreak investigations. She received her DVM degree from the University of Ibadan, Nigeria. She works as a senior veterinary officer and epidemiology officer with the Federal Department of Livestock in Nigeria. She has been involved in investigating several outbreaks of public health importance and has conducted several surveys.
Good afternoon to you all. I'm Mabel from Nigerian Field Epidemiology and Laboratory Training Program. I'll be presenting Lassa Fever outbreak investigation and response among workers at the Ebonyi State University Teaching Hospital, Abakaliki, Nigeria. Lassa fever is a zoonotic hemorrhagic fever in the same class as Ebola, Marburg virus, which was first described in Lassa village in Borno State, northeastern part of Nigeria in 1969. It is an acute viral illness caused by the Lassa virus of the family Arinaviridae. All age groups are susceptible to the virus. It has an incubation period of 6 to 21 days. The reservoir of the virus is a rodent with scientific name Mastomys natalensis. Case fatality rate is reported to be very high as 30%. It's particularly severe in pregnant women, and deafness is a sequela. The mode of transmission is primarily from rodents to humans, either through rodent excreta or urine contaminating food for human consumption, or direct contact through bite from a rodent or by aerosol. Mode of transmission could be secondary, from human to human, either through contact with blood or bodily secretion or fluid from an infected person, or via nosocomial transmission, which occurs in the hospital through needle stick or cut or inhalation of aerosolized virus. Lassa fever is endemic in some states in Nigeria. Ebonyi State University Teaching Hospital, Abakaliki, has been associated with the Lassa fever outbreaks. It reported outbreaks in 2005 and 2008. The 2005 and 2008 outbreaks claimed the lives of 5 nurses and 2 doctors, respectively. In 2011, the only death reported was a kitchen staff in the same hospital, while one of the cases was a nurse who managed her, and other cases were her neighbor and hospital visitor. In February 2011, the Federal Ministry of Health was notified of the suspected Lassa fever outbreak at this hospital. Some of the hospital staff were affected. The common symptoms observed were nausea, vomiting, high fever, cough, diarrhea, sore throat, while the specific symptoms observed were bleeding from the mouth and nose, swollen neck, and conjunctivitis. This slide shows the timeline of activities. On January 24th, the Ebonyi State Ministry of Health was notified of suspected Lassa fever cases. Between January 25th and February 11th, there was an active Lassa fever case search. On February 11th, the Federal Ministry of Health was notified. Between February 15th and 19th, the residents of the Nigerian Field Epidemiology and Laboratory Training Program were deployed to the state, and the WHO team also arrived at the hospital. Between February 20th and March 1st, we reviewed the hospital's line list of contacts, and a Knowledge, Attitude and Practices Survey, CAP, was administered to the hospital staff. This slide shows a map of Nigeria with Ebonyi State highlighted in green. Ebonyi State is located in the southern eastern part of Nigeria. Our objectives were firstly to confirm the existence of the outbreak, secondly to describe the outbreak in terms of time, place, and person, and thirdly to assess infection control measures, and finally to support case management. Our methods. We conducted laboratory testing to confirm the diagnosis. We reviewed the hospital's line list to identify additional cases. The hospital identified 7 persons who had direct contact with the index case. We assessed infection control measures by visual assessment of the facility to observe if barrier nursing was practiced, presence of an isolation ward, and practice of universal precautions using standardized checklists. We conducted laboratory investigation and we carried out a CAP survey among health workers to assess possible causes of transmission. Cases were confirmed using reverse transcriptase polymerase chain reaction test in a high containment facility at a Lassa fever referral laboratory in a rural specialist hospital in Edo State in Nigeria. To identify additional cases, we use the following standard case definitions. We defined a suspected case as a person admitted at the hospital with high fever, unresponsive to treatment of malaria or typhoid fever, and had either bloody diarrhea, vomiting, or bleeding, while we defined a probable case as anyone who had contact with a confirmed Lassa fever case. The hospital conducted case search through contact identification and identified 7 persons for follow-up. We interviewed the contacts and obtained their demographic information and risk factors for infection, such as animal and human contact or food contamination. We collected venous blood from these individuals and tested them using the reverse transcriptase polymerase chain reaction. For our CAP survey, we administered a structured questionnaire to the staff of the hospital. We collected data on socio-demographic characteristics, knowledge on various aspects of Lassa fever, such as case definition, symptoms, case management, mode of transmission, attitudes and practices of the workers during the outbreak. We analyzed our data using the EpiInfo software. We conducted both univariate and bivariate analysis. Our results. Results of the case identification showed that 7 cases were identified and interviewed. 42.9% of them were positive, and of these 3 individuals who were reported positive, only 2 were reported sick. 1 of them was hospitalized, and all 3 of them were treated with ribavirin prophylactically, out of which all of them survived. This slide shows a chart on age distribution of Lassa fever follow-up cases at the hospital. 42.9% of the cases were female, and they were within the age group 21 to 30 years. This slide shows the description of Lassa fever positive cases. The first case was a female aged 30 years, and she was the managing nurse for the index case. The second case was a male aged 57 years who visited the index case at the hospital. And the third case was a female aged 35 years who was a neighbor of the index case. The results of our hospital assessment showed that barrier nursing was not practiced when caring for Lassa fever patients. There were no isolation wards, and universal bowel safety precautions were not always practiced at the hospital. We identified gaps with the infectious disease reporting system. The results of our CAP survey. This slide shows the demographic characteristics of the CAP respondents. The mean age was 35 years. 60.8% were female and 43.1% were nurses. This chart shows the age and sex distribution of CAP respondents. Majority were within the age group 26 to 35 years, and 29.4% were female. This chart shows the knowledge of symptoms of Lassa fever reported by respondents. More than 50% of all respondents knew the majority of the symptoms associated with Lassa fever. Fewer respondents knew diarrhea was one of the symptoms. This chart shows the knowledge of mode of transmission of Lassa fever as exhibited by the respondents. More than 50% of all respondents knew mode of transmission associated with Lassa fever. This slide shows the CAP results by profession. Of the 51 respondents, doctors were most knowledgeable of the symptoms. Of the 36 respondents who managed cases, 36.1% of them wore personal protective equipment, of which 36.4% of them were doctors, 27.3% were nurses, and 20% were health attendants. This chart shows the knowledge of personal protection against Lassa fever as demonstrated by the respondents. Of the 51 respondents interviewed, more than 70% knew the correct method of personal protection. This chart shows the practices of health workers during Lassa fever outbreak at the teaching hospital. 55.1% always wore personal protective equipment when attending to suspected cases of Lassa fever. In conclusion, infection control measures practiced at the hospital was poor. Most healthcare workers knew Lassa fever symptoms and mode of transmission, but did not observe standard infection control measures when attending to patients of the suspected Lassa fever. We carried out the following public health actions. We provided assistance in case management by providing personal protective equipment and drugs for the hospital. We provided infection control education by organizing a workshop for hospital workers with emphasis on the use of personal protective equipment and other safety precautions. Based on our findings, we recommended that the State Ministry of Health should provide routine education and training on bowel safety for hospital personnel. An isolation ward should be made available by the management of the hospital for managing suspected cases of Lassa fever. And then the State Ministry of Health should also intensify surveillance activities for Lassa fever, especially early reporting at the local government and community levels. We would like to acknowledge the following individuals and organizations. Thank you for your attention. Okay, questions? Yeah. Okay, well, from our observation, we realized that, yes, the hospital had some of these equipment in place, but I guess the index of suspicion was just low. They were just careless. Yes, please.
How long did it take between index case being hospitalized and actual recognition of Lassa fever, identification or presentation of bleeding or that kind of recognition, to the point where that's where the staff might start using PPE?
Okay, well, when a case presents at the hospital, it's usually the case presents like other causes of fever, like malaria, typhoid. So people are not usually suspicious at that point because you're not sure what you're handling. And I guess that's why most of the hospital staffs were exposed, because they probably thought it was just one of those fevers, common fevers, and then they ended up exposing themselves and they came down. So the bleeding is usually at the tail end of the disease, so you would have been exposed and you're already infected before you realize that, wow, I'm handling a very dangerous disease. So the whole idea is you should be cautious at the very beginning that you could be handling something very dangerous. So at the first point of contact with the patient, you should protect yourself. Any other questions? Thank you very much.